our next eminent speaker, Dr. Vijaya, and she is going to be talking on a complex topic, eye syndrome. On to you, Doctor.
So at the outset, I would like to thank AIOS ARC, especially Chitra, for this kind invitation and very that's very educative for everyone. So I will be talking to you on eye syndrome. So eye syndrome, iridocorneal endothelial syndrome, is usually unilateral. It is a rare progressive disorder with a broad spectrum of clinical manifestations, characterized by corneal endothelial abnormalities with varying degrees of corneal edema, iris atrophy, secondary angle closure. So there are three clinical variants for the postgraduates to know about it. And one is the progressive iris atrophy, where the changes are mainly in the iris. And the second one is the Chandler syndrome, where the changes are mainly in the cornea. The third is the Cogan-Reese syndrome, characteristic of very small nodules on the iris surface. There can be overlap stages between the three. The etiology is not very well known, but majority believe that it may be of the viral etiology. And most of the times people were able to isolate the virus-related substance from the aqueous tap which was taken at the time of the surgery. And most of the time it is a herpes-related etiology. Coming to the symptoms, most early stages it is asymptomatic. And with the time, the people will develop pain and blurring of vision due to the corneal changes or elevated intraocular pressure. And many patients will complain of change in the pupil size and the position. Signs are increased myopia, microcystic corneal edema. Corneal endothelium will have a characteristic fine hammered silver or beaten bronze appearance. Iris changes can be heterochromia, ectropenia, polychoria. Gonioscopy characteristically shows angle closure. Specular microscopy will have abnormal large round pleomorphic cells with a typical light dark reversal. And in Cogan-Reese, you will see nodules like what you are seeing here. And the treatment is, people start with the medication, but usually very poor prognosis in spite of maximum medical treatment. IOP control is poor because there is high failure rate with the surgery. Tube is preferred surgery in this size. Often this size will need even ciliary ablation. Here is a case of eye syndrome managed by us, 49-year-old male complaining of pain in 2 months, diagnosed as eye syndrome 10 months back. Intraocular pressure was 34 millimeters of mercury, was on maximum medication, and the pressure was not under control. This is the clinical picture. It fits into Chandler's. You can see the beaten silver appearance of the corneal endothelial surface. So they decided to do the surgery for this patient. The choice is again the tube. AGV was done. The challenge is because of the extensive synechiae and being phakic, where to put the tube. So this surgery was done by my colleague, Dr. Parivardhini, and the superior nasal quadrant. The AGV was positioned. So after securing the plate, and an iridectomy was done first using a limbal incision, using the light pipe, and 2 millimeters away from the limbus, and a track was created for insertion of the tube into the sulcus. And light pipe is a good tool intraoperatively to visualize a hazy cornea. And using that, tube was inserted into the sulcus, and you can see, and it comes out through the PI. That is the purpose of the PI, so that you can insert the tube into the sulcus. So this follow-up at 6 weeks, you can see the well-placed tube. Pressure is under control. Vision was 6/18 with 1 AGM. Pressure was 10 millimeters of mercury. And at the follow-up of 1.4 years, the intraocular pressure is maintained, but the vision reduced because of the progression of the cataract that needed intervention at a later stage. So in general, eye syndromes don't do well. Majority of them will progress or worsen with the time. And unfortunately, majority of the patients also present to the clinic at a very late stage because they are not aware that they have the problem. The endothelial proliferation that keeps happening contributes to the failure of the surgery. So when the tubes doesn't work well, one may have to resort to the ciliary ablation. Thank you. Thank you very much.
Thanks a lot, Dr. Vijaya. I mean, your topic was so complete. I don't have questions. A tube is the only way to go. And of course, you would suspect it more commonly if it's a unilateral presentation and a middle-aged female are the common presentations. And of course, all the signs you said. Any question from the expert panel, or should I go on to the last two speakers? Dr. Shushmita.
Is there any role of trabeculectomy, especially in phakic patients with shallow AC? Do you ever do trabeculectomy?
You can do it, but the failure rate is very high. So that is the reason we started directly going for tubes rather than doing the trabeculectomy.
Can I add a couple of points?
Yes.
You know, I completely agree that that going for tube as a primary surgery is probably the best thing to do because of the failure of a trab. But even with the Ahmed glaucoma valve, sometimes, you know, it doesn't really bring down the pressure in every single patient. And that, you know, that's really very upsetting. The other important thing in these patients is because of the endothelial proliferation, when these patients do develop a cataract, then there's a very high chance that, you know, the cornea will go for decompensation, if not immediately, then over a period of a few months or a year or 2 years. So it's a real challenge dealing with these patients, actually.
Yes, thank you. That was a very valuable